Okay, ma. Good night, ma.
Hey, good night.
Yes, ma. Yes, ma.
Okay, can you see my screen?
Yes, we can see your screen.
All right. So, good evening, everybody. So today's case will be a case of left pyelonephritis and cystitis secondary to urolithiasis. The family physician as a coordinator of care. So here our index patient here, MH, is 41 years old, a lady. She's married and a civil servant, lives in Garki 2. She was admitted on the 26th of March 2020 and discharged on the 29th of March 2020. So, sorry, I moved this too fast. All right, the presenting complaints were recurrent left lower back pain of 8 months duration, fever and lower abdominal pain of 6 days duration. She had been in good health until 8 months prior to presentation. When she developed left lower back pain. It was sudden and in onset, sharp and non-radiating with no aggravating factors, but was relieved by taking diclofenac or paracetamol. Pain intensity was oftentimes said to be mild but occasionally severe. A week prior to presentation, pains had persisted and worsened, interfering with her normal daily activities. About the same time, MH developed high-grade fever, intermittent fever with occasional chills and rigors, which was relieved by paracetamol. There was also associated lower abdominal pain, described as being dull in nature and related to the lower back. There was dysuria and increased urinary frequency at about the same time. She had no vaginal itching, neither did she have any abnormal vaginal discharge. MH was particularly worried about her health condition and feared that it may worsen her state of infertility. She believed it resulted from the urethral catheterization done on her several months prior to presentation when she underwent IVF session in a private hospital facility. So she was expecting to get pain relief and get cured of this disease. So she had no history of vomiting, diarrhea, or jaundice, no history of cough or difficulty in breathing. MH also had no history of headache, fainting spells, or convulsion. She attained menarche at the age of 13 with a catamenia of 4/28 regular day cycle. There was no history of dysmenorrhea. Coitarchy was attained at age of 16 years, and was consensual. She became menopausal, however, 2 years prior to presentation. But prior to that, she had about irregular menstrual flow for about 4 years. She also had primary infertility after being married for about 10 years, and she had attempted IVF twice before the time of presentation. They were both unsuccessful. She had been admitted on 2 occasions in the preceding months for similar symptoms and was treated with courses of antibiotics. She had hysteroscopy the previous year when she was being managed for primary infertility. She was a known peptic ulcer disease patient, but was, however, not a known diabetic, hypertensive, asthmatic, or sickle cell disease patient, and she has had no history of blood transfusion. She was a civil servant working with the Ministry of Finance. She was married in a monogamous family setting. Her 45-year-old husband was also a civil servant. They lived in a rented, well-ventilated 2-bedroom apartment with water closet, toilet system. Their source of drinking water was pipe-borne water, and their total monthly income was about 400,000 naira per month. She had no known drug allergy. I hope you are following. Her abdomen, okay, on physical examination now, MH was actually acutely ill-looking and febrile with a temperature of 39 degrees centigrade. She was anicteric, not pale, not dehydrated, and had no pedal edema or peripheral lymphadenopathy. Abdomen was full and moved with respiration. There was tenderness in the suprapubic region, and there was also left renal angle tenderness. The liver, spleen, and kidneys were not palpably enlarged, and her bowel sounds were normal. Her respiratory rate was 20 breaths per minute. Trachea was central, and percussion notes were resonant. Her breath sounds were vesicular with no added sound. Her pulse rate was 100 beats per minute, full volume and regular. Her blood pressure was 130 over 80 millimeters of mercury, while her apex beat was at the fifth left intercostal space on the mid-clavicular line. The first and second heart sounds were heard with no murmur. She was conscious, alert, and oriented in time, place, and person. There were no cranial nerve deficit noted. There were no signs of meningeal irritation. Muscle tone was normal globally, and she had full power in all limbs. So with this history, a provisional diagnosis of left pyelonephritis was made with left urolithiasis as a differential. So this diagnosis, the need for admission, the need for IV antibiotics, and need to investigate further to rule out urolithiasis was explained to her and her husband. They understood and consented to the admission. She was then admitted into the female ward. Blood samples and urine samples were taken for full blood count, malaria parasite smear, HIV screening, EUC, urinalysis, urine microscopy, and urine MCS. She was commenced on intravenous levofloxacin 500 milligram daily. She was given a start dose of intramuscular diclofenac, some 5 milligram daily, and some 5 milligram daily, and then also on oral naproxen, omeprazole, 500 milligram / 20 milligram twice daily. So 4 hours after admission, some of the investigation results were coming out. MP was negative, parasite was negative, pack cell volume was 36%. And full blood count showed leukocytosis with a count of 13,500 cells per millimeter cube and neutrophilia of 80%. Reanalysis showed leukocytes of 3 pluses and nitrites of 1 plus, which were both suggestive of UTI. Random blood glucose was 10 millimoles per liter. HIV counseling was done and she tested negative. So a pelvic ultrasound scan was also done, which revealed a thickened bladder wall with internal echoes in the bladder lumen, which was suggestive of UTI. There was also dilatation of the left pelvic calyceal system, which also signified some level of obstruction. So on day 1 on admission, she had some pain relief after a few hours on admission, but was still febrile, and so intravenous paracetamol was added to her medication at 600 milligrams 8 hourly. Having discussed with the managing consultant, she was counseled to have an abdominal CT scan to check for the possibility of kidney stones. She agreed to it and gave her consent and was subsequently done. The CT scan images were viewed and some opacity was noted around the left kidney, and this was suggestive of a kidney stone. However, the official report was yet to be released, as of the consultant radiologist was yet to report it. So on the next day, day 2, she was still febrile with a temperature. She was now afebrile with a temperature of 36.8 degrees centigrade, and pains had significantly subsided. She had no new complaints. CT scan report was ready and confirmed the existence of a kidney stone located at the ureteropelvic junction, measuring about 10 millimeters by 7.5 millimeters. The urology team was invited to review her, and they later did that day and updated the consultant urologist. Day 3 on admission, she was much better with no new complaints. The urine MCS was ready now, and it showed a growth of Pseudomonas aeruginosa, which was sensitive to levofloxacin, and hence levofloxacin, IV levofloxacin was continued. The consultant urologist reviewed her and commenced conservative management for her, which involved continuous hydration with intravenous fluid, supplemented with liberal oral fluid intake, and continuation of the analgesics and IV antibiotics. These measures were to observe for possible spontaneous passage of the stone, and she was then scheduled to see him as the consultant urologist in 2 weeks. So, day 4 on admission, she was much better with no new complaints. Pains and fever had completely stopped. All vital signs were stable and within normal range. All her parenteral medications were converted to oral. She was then discharged on tablets of levofloxacin 500 milligram daily for 2 weeks, and the naproxen for 520 milligrams, so 20 milligrams for twice a day for 5 days. She was counseled to also see the gynecology clinic for follow-up on her fertility challenges and possible repeat trial of IVF. She was scheduled to be seen in the general outpatient clinic for follow-up after a week. So the first follow-up visit, that's a week later, she had no complaint. She had just finished her analgesic, but was still on her antibiotics. Physical examination was normal, and she was booked to see the urologist the following week. So that's 2 weeks after discharge, that's the following week, she was seen in the clinic, and she had finished all her medications by then. She had no new complaints. Her physical examination was also normal. She was then seen by the urologist on the same day and had a repeat CT scan, CTIVU, which revealed that the kidney stone was still in place, and so she was scheduled for lithotripsy the following week. So the third follow-up visit, the third follow-up visit, that's a week after the last visit, she was seen in the urology clinic and admitted for lithotripsy. And she had lithotripsy, extracorporeal lithotripsy, the following day, after which she passed fragments of the stone in urine and was discharged 24 hours after the procedure when she was pain-free and much stable. She was seen a week after the procedure again in the urologist clinic. She was symptom-free. Stone analysis revealed calcium oxalate content, and she was at this point discharged from her urology clinic and advised to present to the gynecologist whenever she was prepared to attempt another IVF. So in summary, this was a 41-year-old female who presented with history and clinical findings suggestive of left pyelonephritis with cystitis secondary to left urolithiasis. She was promptly admitted, treated with intravenous antibiotics, and later had extracorporeal shockwave lithotripsy. So the discussion now, UTI is basically defined as the microbial invasion of any of the urinary tract tissues, ranging from the renal cortex to the urethral meatus. It is known as simple cystitis, that's bladder infection when it affects the lower urinary tract, and known as pyelonephritis when it affects the upper urinary tract. Pyelonephritis is basically renal parenchymal inflammation, and symptoms may be characterized by inflammatory symptoms, sometimes fever, coastal vertebral angle pain, and nausea or vomiting. And this index patient, MH, had both components of pyelonephritis and cystitis based on her presenting symptoms of fever, left lower back pain, and lower abdominal pain. In Africa, UTI is one of the most common human bacterial infections seen in both community and hospital settings, affecting all ages and both sexes. In Nigeria, a study by Otajewo et al. Done on outpatients in University of Benin Teaching Hospital showed a prevalence rate of 39%. Some of the risk factors associated with occurrence of UTI include female gender, short urethra, increasing age, peak age being within 16 to 35 years, diabetes, pregnancy, immunosuppression, obesity, urethral catheterization, urinary tract stones, frequent sexual intercourse, and use of spermicide and diaphragm. In our patient, MH, she had several risk factors for the development of UTI, and this included her age of 41 years, which fell within the peak age group, the female gender, urinary tract stones, history of urinary tract stones, and a history of urethral catheterization. And all these may have predisposed her to this condition. Most cases of UTI are due to rectal and perineal floral colonization of the urogenital tract. Hematogenous spread can, however, still occur to the urinary tract. And the most common organisms implicated are E. coli, Enterococcus, Klebsiella, Pseudomonas, and Staphylococcus. The causative agent isolated in MH was Pseudomonas aeruginosa, which is one of the commonest organisms implicated in this condition. Urolith literally means calculus or stone in the urinary tract. They are solid masses which are formed from minerals in urine in the urinary tract. Isaac et al. In a study done in the University of Abuja Teaching Hospital reported the prevalence rate of 13.4 per 1,000. And some of the risk factors associated with urolithiasis include dehydration, increasing age, peak age being between 21 to 50 years, family history, male gender, obesity, UTIs, and Western diet, that's processed food with additives, high environmental temperatures, metabolic disorders such as gout, hyperparathyroidism, drugs such as diuretics, etc. So risk factors identified in this particular patient were age of 41 years, history of a UTI, and having calculated her BMI, which fell at the value of 31.2 kilogram per meter square. It categorizes her as obese, and this is also a risk factor for urolithiasis. Her female gender, however, does not fall in the list of risk factors, as urolithiasis studies have shown slight male preponderance. CT scan is the gold standard for diagnosis of urolithiasis. And MH, that's this particular patient, had abdominopelvic scan, which revealed features of cystitis and dilatation of the left pelvic calyceal system. And the ureteropelvic junction is the commonest site of stone formation. And she had CT scan, which revealed a stone at that left ureteropelvic junction. So in management of UTIs, most organisms showed sensitivities to fluoroquinolones, cephalosporins, penicillins, carbapenems, nitrofurantoin, and cotrimazole. Pseudomonas aeruginosa was the isolated the MH showed sensitivity to levofloxacin, and so formed the basis for use in her management. The treatment options for urolithiasis include watchful waiting, stone dissolution, medical expulsive therapy, extracorporeal therapy, endoscopic lithotripsy, intervention, and open surgery. This particular patient had extracorporeal shockwave lithotripsy, which was done, and she passed fragments of the stone in the urine. So in conclusion, one of the lessons learned is that urolithiasis can predispose an individual to urinary tract infection and vice versa, especially for gram-negative organisms like Pseudomonas aeruginosa. That is, gram-negative organisms can cause formation of stones, called as struvite stones. And studies have shown that urolithiasis and UTI are becoming increasingly more common in our environment. Family physicians are expected to be able to identify and diagnose urolithiasis and the different types of UTI when they encounter such cases. So a good knowledge of the etiology, predisposing factors for both conditions will aid us in educating and counseling patients and the general public on preventive measures. Prompt management will help in preventing renal failure and other complications associated with these conditions. So these are my references here. Thank you very much for listening. So I'll end, or let me still leave my slide open. Hope we are together.
Yes, Chief, we are together.
All right. Thank you. So questions,
Can we have
comments?
Medical officers, questions, residents. Dr. Binde.
Sir?
Yeah, ask your question.
I do have a question. Chief, I don't have question.
Or any comments?
Or comments? Comment is good presentation. Yeah. I don't have comments. Sir.
Yeah, now, Doctor.
No comments. Sir.
Trudy.
Good evening.
Yeah, good evening, Dr. T.
Okay, I don't know, sorry if I missed it because I'm feeling a bit tired. It's been a long call for me,
Okay.
but I was just wondering, did we test the woman's partner for any sign of infection?
Well,
The
yes,
woman's sexual
just
partner.
the sexual, yeah, the husband was just asked if he had any features or symptoms of UTI, but as regards culture, urinalysis, or any laboratory test was not done. It was not done for this patient.
I see. I see.
Yes, it was not done.
But is it likely to be relevant in urinary tract infection? That's the question. Is it necessary to test when
I
a patient
don't
has
think
a
it's
urinary tract?
necessary. I don't think it's necessary. I don't think so. To test the partner. It's not like STI. I don't think it's necessary, but I don't know. I've not seen any study or any literature that talks about testing
No, I
the
don't.
partner.
I don't. Yeah, I don't think so. I've not seen anywhere.
Yeah. Although part of the risk factors for urinary tract infection, I think it's frequent sexual intercourse for females.
That's
Yes.
that honeymoon society stuff, Abi.
Yes, honeymoon
Yes.
societies. Yes.
Yes.
Yeah. Yes.
But that. Yes. But that it will be a sexually transmitted infection. I'm not. That may not be entirely needed.
Yes, because the major way is like pushing of the perineal flora into the the vagina and the urinary tract. So it's not basically coming from the partner. It's what was already there that's been pushed upwards to the urinary tract. So I don't think there's any basis for testing the partner for that. Any other question?
I was just wondering if, so if in some females, you test E. coli as part of the flora in UTIs. And we know that most times it's an apparent contamination from the after moving their bowels, and then they clean from back to front.
Sorry, you are breaking up. We can't hear you well.
They can infect their partner.
Dr. T, we can't hear
It's
you.
my network.
I'm not here. Can't hear your question.
My network is bad.
Okay, network issues. Okay, sorry.
Yeah. I'll pass.
It's still breaking. Still breaking. Okay, I think he's having network challenges. So do you have any other comment, question, contribution? Dr. Akins.
Hello? Hello?
Your network is really fluctuating, Dr. T. It's breaking seriously. We can't hear you.
Yeah, I know. Can you hear me?
It was still cracking anyway.
Can you hear me?
It's all on off.
Network. Network. All right, Dr. Akins, I think network is interfering with Dr. Taiwo's comment and contribution.
Oh, well. Okay, then. I'll discuss it with you.
Dr. Akins, are we closing the meeting? I think he's having network issues. So if there are no other comments or contributions, I think we'll end the meeting now. All right, good night, everyone. I think that's it. Any other comment? Nothing?
Okay, don't worry. It's not.
Okay. All right, let's end the meeting. Let's all have a good evening. Thank you, everyone. Thank you. Thank you. Good night.
Thank you, Chief, for the presentation. Thank you so much.
Thank you. Yeah, good night, everyone. Yeah.